Good afternoon and welcome to this public meeting of the Standing Committee on Social Development. My name is Kieran Testart. I'm the MLA for Range Lake and filling in for Jane Whalen Armstrong as acting chair of the Standing Committee on Social Development. I'll now ask members in the room to introduce and online to introduce themselves for the record. We'll start with Ms. Morgan.
Good afternoon. I'm Shauna Morgan, the member for Yellowknife North.
And online we'll start with Ms. Whalen Armstrong.
Hi, yes, Jane Whalen Armstrong, MLA for Mofi Klitschou region. Thank you.
Hello, Cheryl Yakalaya, member for the DECHO. Thank you.
Thank you, members. Today we are joined by officials from the Department of Health and Social Services and from the Northwest Territories Health and Social Services Authority to receive a technical briefing on harm reduction programs in the NWT. Please note this meeting is being live streamed to the Assembly social media channels. I'd like to remind all members and witnesses to direct all questions and comments to myself as the chair and to wait to be recognized before speaking to help us have a smooth and orderly meeting. I will now pass it over to our witnesses. Please introduce yourselves and proceed with your remarks and presentation. Dr. Ken, no.
Thank you. Good afternoon, and thanks for the opportunity to be here today to speak with you about harm reduction services available in the Northwest Territories. My name is Sarah Charskowski, and I'm the Assistant Deputy Minister for Programs with the Department of Health and Social Services. I'm joined today by officials from the Department of Health and Social Services, as well as the Northwest Territories Health and Social Services Authority. From the department, I have Dr. Cami Candola, the Chief Public Health Officer, Ms. Jenna Scarf, who's the Director for Mental Wellness and Addictions Recovery. And from the Northwest Territories Health and Social Services Authority, we have Shauna Gilmore, who's the Territorial Lead for Addictions and Recovery. So the issue of addictions is significant in the NWT, and it does remain a top priority for the health and social services system. The journey to recovery is not linear, and nor is it the same for everyone. So in light of this, the health and social services system continues to focus on ensuring a variety of supports and services for individuals impacted by addictions, including harm reduction. While the purpose of harm reduction is not to treat addiction or its underlying causes, it is understood to be a best practice for reducing the harm associated with addiction and the overall impacts on and costs to the health and social services system. Harm reduction efforts are an important element of a comprehensive approach to supporting individuals and to promoting public health and public safety. So I'm now going to pass the floor to Dr. Candola and Ms. Gilmore, who will provide a presentation on public health and harm reduction strategies that are being led by the health and social services system, and we will be happy to answer any questions you may have following the presentation. Thank you.
Thank you. Dr. Candola?
I will end.
Okay, let's go.
I don't know if it's slow or if I'm just, okay, there we go. Just not pushing the button hard enough. Okay, so thanks so much for having us today. I'm just gonna frame up the discussion a little bit so that everybody's kind of on the same page about what we're talking about. So public health practice is comprised of health promotion, health protection, and the prevention of illness, injury, and disease. Harm reduction can refer to multiple things. It's typically related to public health initiatives that are aimed at reducing harms associated with substance use and other stigmatized behaviors and practices. But ultimately, the idea of public health with health promotion, health protection, prevention of illness, injury, and disease, those pillars of public health practice is what guides the approach to harm reduction as well. So the primary purpose of many harm reduction initiatives is actually to reduce the risk of spreading infectious diseases. So initiatives will often arise in response to a specific need, and they should be tailored to the local context of what's happening in that community or in that region. Harm reduction approaches in general are evidence-based, they're cost-effective, and they help enable people to increase control over their health. So as Sarah mentioned, harm reduction approaches don't treat substance use disorders, but they can be a really critical component to help connect people to services that can help support recovery. So the idea of harm reduction as outreach can allow us to engage with folks and those services can often be like a first step to people thinking about making a change and kind of moving along that path to recovery. Even if folks aren't ready yet, it's still really important for those of us who work in the health and social services system to let folks know that we are there for them, no matter where they are in their kind of readiness, so that they know that once they are at that point that they're looking to reach out to kind of help move along with treatment, that we're there to help them. Addiction is really complex, and people with substance use disorders often have a history of mental health issues or trauma, grief, and other types of contributing factors. And the first step to recovering from trauma in particular is to create a sense of safety and stabilization. So processing and dealing with trauma is really difficult when people still feel unsafe. So harm reduction initiatives can help support that sense of safety and provide some stability in people's lives, which can then help influence their journey towards recovery. So to get into some examples of harm reduction initiatives that we have used in the territories, safer injection supplies is a common topic that comes up. Needle distribution aims to reduce the risk of spreading bloodborne infections, so things like hepatitis C, HIV, and other complications of using contaminated equipment, so things like tetanus, bacterial infections. These types of initiatives have been shown to significantly reduce short and long-term healthcare costs. And these services have actually been available in the territory since 1991. So it began in Yellowknife region. Obviously, this was well before amalgamation, and it was just through a public health response to a demand that was occurring at the time. People don't just use safe injection supplies for things like heroin. That service is also accessed for things like steroid use, for example. So the public health programs in other regional hubs have also been offering this service kind of on an as-needed basis where there is demand for that. But it is really notable that injection isn't now and has not really ever been a very common use of drug use in particular, not a common method. So the demand for needle distribution program is extremely low, and it is actually like none in some regions. So the data on that is relatively limited, like the number of folks that are actually accessing that type of a service. Safer inhalation supplies is another one that is a little bit more a little bit newer in the overall realm of harm reduction. Inhalation supplies, so things like crack pipe kits, for example, can reduce the risk of transmission for infections as well. So things like Hep C, MRSA, and also like respiratory illnesses like COVID, tuberculosis. So these types of kits really became a lot more kind of prevalent in the harm reduction world during the time of COVID, so that people aren't sharing crack pipes and distributing infection in that way. It can also be really helpful to have this equipment available to help reduce the risk of injuries. So things like cuts, burns, and inhaling fragments from homemade equipment. And my slide deck just went down for a second. Okay. So, we see issues like melted plastic or fragments of steel wool that are used as filters in crack pipes. So these can really cause significant issues for folks, and having the safer options for people to use can be really helpful from a preventative standpoint. Availability of inhalation supplies has been shown to reduce the incidence of injection drug use as well. And the initiative for distribution of safe inhalation supplies started around 2019, also in Yellowknife region in response to demand from service users. But the supplies for this in particular has only kind of had occasional funding. It's usually being funded through kind of various one-time sources. But about an estimate of around 5,000 safe inhalation kits have been distributed in Yellowknife since February of 2023. So that one is certainly much more commonly accessed than the safer injection supplies. Safer snorting supplies, another one that came from an identified need. I was actually working at Public Health when we started doing this in 2016, and it was in response to some events that were happening in the city where we were seeing more snorting. of substances, and there's a risk of transmission for things like hepatitis C, respiratory infections, and MRSA. So if people are putting straws in their nose and they cut the inside of their nose and there's a little bit of blood on that, and then they pass it to their friend who sticks it in their nose, and then you get disease transmission from that. So packages of straws with educational pamphlets on the risks of sharing this type of supplies have been distributed through Yellowknife Public Health just in response to that particular issue. All right, so shifting gears a little bit, managed alcohol programs. This is something that provides a set dose of beverage-based alcohol in a safer setting. So the aim of a managed alcohol program is to limit intoxication levels and consumption of non-beverage alcohol. The managed alcohol programs work to preserve the dignity of the person and increase access to healthcare, social and cultural programming, and they've been shown to increase safety, quality of life, reduce harms from alcohol, and also decrease police interactions and emergency department visits. So managed alcohol programs can take place in a couple of different settings. Community-based MAP has had begun during the pandemic to support clients during periods of isolation, and then that continued later through the Spruce Bough program. Results from this initial initiative had informed the development of territorial standards. The program itself is relatively new, and given kind of how it came into being, the stability of it has been impacted a bit by a lack of permanent resourcing. So our data collection to measure the outcomes and the impacts of that program is still ongoing. But that being said, the Canadian Research Initiative in Substance Matters has actually provided some funding to support a study gathering feedback from the residents and participants at the Spruce Bough program. So we're eagerly awaiting the results from that project. The other place that we see managed alcohol programming is in the inpatient setting. So this was also started during the pandemic. And the goal of this is to help manage the symptoms of alcohol withdrawal for people who are admitted to hospital for reasons unrelated to their alcohol use. For example, if somebody breaks their leg and is going to be admitted to the hospital for a period of time. There's some options there on what they want to do. It may not be ideal for that person to immediately cease alcohol consumption and end up experiencing potentially really significant effects of alcohol withdrawal while they're also experiencing another potentially kind of critical illness. So hospital-based MAP initiatives have been shown to reduce overall alcohol consumption, actually, and to reduce the rates of people leaving hospital prior to completion of their medical or surgical treatment. Alcohol withdrawal syndrome can be deadly, and the symptoms of withdrawal can also complicate other health issues. We also know that detox alone isn't a treatment for substance use disorder, and detoxing by itself has been shown to have little to no impact on long-term substance use behaviors. So if a person comes into hospital and they're not at the point of wanting to pursue treatment and recovery, and they end up kind of being forced to medically detox from alcohol, then that can have kind of negative repercussions in the long run on that person's recovery path. All right, so moving on to opioid use disorder. Long-term remission from opioid use disorder can be achieved with effective treatment and follow-up. The first-line treatment for opioid use disorder is what's called opioid agonist therapy. So these are medications like Suboxone, methadone, and ideally the provision of these medications is going to be combined with behavioral and social supports. In the short-term kind of like abstinence-based treatment programs, specifically for opioid use disorder, are actually associated with really high relapse rates. And that's a significant risk for people because if someone has opioid use disorder and, for example, they're using like illicit fentanyl and they were to kind of pursue, let's say, like a detox approach to that, and they quit using and then they relapse, they've now lost their tolerance to that substance, and the chances of them overdosing if they go back to using again is extremely high. So there's a significant increase in the risk of overdose and death from a short-term abstinence-based approach, whereas these medications can offer stability and kind of stabilize that cycle of intoxication and withdrawal for opioids. And then eventually, we can taper people down off those medications in a more of a controlled way because they are longer acting than something like fentanyl, which is going to hit quickly and wear off really quickly. So these medications really help people to experience like improved health and social functioning in multiple ways. There's a reduction of the risk of overdose and all-cause mortality, but also, you know, things like social life stabilization and other benefits like that from moving people away from kind of the illicit drug trade. So we do have a territorial opioid program. We're in the process of renaming it to the Opioid Recovery Program. This program provides guidance for use and monitoring of medications that are used to treat opioid use disorder, and we coordinate client care throughout the territory. So the program is available either for consultation with community-based providers, if there is a provider in the person's community that is able to do this work, and then in situations where, say, a community doesn't have a consistent provider to follow the individual who needs help, then the territorial program will carry on providing services and support to that person for as long as they need it, if they don't have a permanent practitioner available in their community. So the goals for opioid use disorder recovery can include having harm reduction in the form of reducing a person's risk of overdose, reducing reliance on illicit opioids to manage their withdrawal symptoms, and then of course reducing their injection drug use and subsequently the risk of infection transmission. There's also some significant social impacts of doing this. So reducing the reliance on illegal substances means that we're helping to guide people away from like a life of crime, right? So we see improvements in housing, in, you know, the ability to work, you know, just kind of getting away from that life and having some stability. And of course, it also improves their overall access to healthcare services because the program will provide like primary care services to the clients that are enrolled in that program. So the opioid recovery program was expanded in 2019. It used to kind of just be available mostly in Yellowknife, and then we went territory-wide, and we have over 60 clients that we support with opioid use disorder. I was actually the first nurse specialist to be added into that program, so it's really close to my heart, and I would, I'm going off script really briefly, I would love to be able to highlight some of the success stories that we've seen in our territory of people putting in the work to move through this process of recovery from opioid use disorder. I cannot stress how impressive it is. Obviously, these are people's personal health stories, so I can't get into the specifics, but I feel really, really passionate about the success of this program and the people that have committed to the program, to putting in the work. So I just want to highlight that the clients or residents of the territory have really had phenomenal stories. So that nurse specialist that got added to the program dropped our wait times from over a week to a business day or less. We can typically get people started on medication treatment like right away within 24 hours, and we've had a program retention rate of over 90%. The majority of the losses in that retention have just been related to people moving out of the territory for work. So the stability of being on treatment and, you know, connecting to those resources, we've had a lot of participants that have gotten into stable housing, they've disengaged from illegal activities, they've obtained and maintain jobs, they've gone back to school, you know, they've been able to provide better care for their children, improve relationships with their families. So it's really a holistic wraparound service, and yeah, it's close to my heart. All right, and with that, I will hand it over to Dr. Candola.
Sorry, I have to, yes, go through me, Dr. Candola. Dr. Candola, you can take over.
Thank you, Chair. So good afternoon. Just wanted to provide the context of what we're living in Canada, so, and then relate to what we've seen in Northwest Territories. So in Canada, since January 1st, 2016, all the way up until March 2024, we've had about 47,000 deaths related to opiate toxicity in Canada. And when you break down the profile of those deaths in 2024, most of these deaths are happening in 3 provinces, BC, Alberta, Ontario, about 84% of the deaths. If you had to have a profile of what these toxic deaths would look like, 7 out of 10 times it would be a male, and the vast majority would be young, under the age of 50. In fact, 1/3 of the deaths are in the ages of 30 to 39. So which specific opioid are they dying from? 81% is fentanyl, and most of the time that fentanyl is unregulated, so it's a synthetic fentanyl that they're obtaining from street, not from regulated pharmaceuticals. And what's interesting is when they look at the deaths, they have seen 61% of those deaths also tested positive for a stimulant. And when you look at Northwest Territories, we've had 27 officially counted opioid-related deaths, but that is an underestimate. If someone from the Northwest Territories, for instance, was to die, to go down to Alberta or BC or another jurisdiction and was to die from an opioid toxicity, that death would not be counted in the Northwest Territories. That death would go to the coroner of that specific jurisdiction, but there is no sharing of data. So this leads us to an awkward situation where we are going into communities and they know the loved ones have died and they know what they died of, but we can't actually count them, but we still have to provide compassion and services, recognizing that that death would not be captured in our Northwest Territory statistics. So there is a changing picture around opioids. Back in, like, we started to see fentanyl in the pill form, the greenies, around 2015. 2016 was an unusual year that we had a large RCMP bust, and we also had a rash of overdoses and deaths. But this was specifically related to people who knowingly knew they had taken an opioid or fentanyl. There was a task force developed, and there was naloxone was provided. There was an intense campaign, and it was successful because there was a significant drop in people wanting to use fentanyl or opioids. So we didn't consider Northwest Territories as an area that we saw a fentanyl problem or opioid problem because people preferentially chose crack cocaine, and as Shauna Gilmore talked about, injection drug use is not something that we see here. And if people were experiencing an opioid addiction, they either came into the jurisdiction with it or it was related to prescription opioids. But things changed during the pandemic. And what we start to see in the pandemic, there was a shift in the ability to access natural opioids or heroin because of the lockdowns, or even accessing cocaine from South America. Those supply chains changed. And when those supply chains got disrupted, we had some innovative manufacturing of synthetic compounds that were added to like the crack, or added to other substances where it was no longer pharmaceutically regulated compounds, but you had illegal opioid manufacturing distribution sites, whether it's in Mexico or Canada, that were using precursors mainly imported from China. So why I'm talking about this is because specifically in 2022, we had 6 deaths in Hay River. And when we did a deeper dive on these deaths, the coroner and I, we noted that all these individuals were using crack cocaine. They were essentially alone when they died, and they had no access. There was no naloxone. There was no access to naloxone, and they were thinking they were taking a stimulant, so they had no idea that in that stimulant was a very powerful depressant, a very powerful, potent opioid. So during that period, it really shifted our focus. Typically, we would, before that, we would have talked about opioid overdoses, but when that started to happen, the language switched to opioid poisoning, and sometimes when you don't know, we call it opioid toxicity, which covers both. So opioid poisoning basically is that an individual thought they were taking one substance, but it was contaminated with another substance. The overdose is when they know they're taking an opioid, they know, but they've taken too much of it, or they've decreased their tolerance to it. So what we noted in 2022 was we had to reclassify that as opioid poisonings, and that really shifted the whole approach of public awareness that we ended up seeing this pattern repetitiously. In fact, over this period, I issued 14 public health advisories, and mainly related to contaminated substances. And as time went on, we noticed more and more contamination. So where we would see crack cocaine contaminated with fentanyl or carfentanil or other fentanyl analogs, as time grew by and we got more toxicological reports, we noticed that they had a benzodiazepine with it. So they had a sedative that doesn't respond to naloxone. Or most recently, when I issued an advisory in Hay River in June around brown crack, it had crack cocaine, it had fentanyl analogs, it had crystal meth, and it had benzodiazepines. So increasingly, we're recognizing the supply is becoming more and more toxic. And this is not unique to NWT. This is what we're seeing across the US and Canada. So next slide. Oh, thanks. It's just magically going to happen. Okay. So we realized that we not only had a cluster of deaths in Hay River related to opioid toxicity, we also experienced a cluster of deaths in Beaufort Delta, but that cluster of deaths occurred mainly outside of Beaufort Delta. It occurred in Yukon. There was some that occurred in Beaufort Delta, but again, it related to opioid toxicity. When this occurred, the communities, along with the public health advisories, there was a demand from communities and indigenous governments and elders to say what is happening, because, you know, this is new to them, opioid toxicity. This is new. They're starting to see a change in the drug culture. They understand alcohol. They may understand the impact of cannabis, but this was new. So they wanted to know what type of drugs are out there, what's opioid toxicity, what can we do, and how do we stop this, and where can we learn more. So this demand for knowledge led us to start developing specific awareness campaigns, but also we realized that even though we have core funding for naloxone that's distributed through health centers, ERs, and pharmacies, that we needed a surge response. So we literally, since 2022 up until now, we dispensed over 2,000 kits of naloxone. We provided naloxone training. We are going into communities, talking to governments, talking to multiple conferences, like what the differences between stimulants and depressants, how they can be mixed together. How do you recognize signs and symptoms of opioid toxicity? How do you use naloxone? Also calling for help. And in addition, we also distributed fentanyl test strips, so because that was something that people wanted to test their own drugs, knowing that a negative doesn't mean anything because there are stronger opioids that test negative. But this campaign started with that crisis in Hay River, like January of 2023, when I had the press conference with the chief coroner, and we realized that people are unknowingly taking toxic substances but not knowing, and that we needed to raise awareness of what was happening. Next slide. As we dove deeper into this scenario, I'll do messaging for me. One of the things we're trying to understand, there was typically NWT was known not to have a contaminated supply, and so the drugs were starting to become contaminated, and we're trying to figure out why. So we were doing deeper dives, talking to people who lived experience, connect with RCMP, saying what shifted. And we know what shifted was the disruption of the supply chain because of the COVID pandemic. And so then you had an increase in synthetic production, but we thought, was this intentional? And why would you want to mix all these drugs into crack cocaine or other substances? But what's basically been happening is when you look at there's crack cocaine, which is a stimulant, and then you add the fentanyl, which gives you a quick high, You add the benzo, which prolongs the high. You add crystal meth so they can stay awake to enjoy the high. And you add all these things for however they want to present this. And this is intentional. And so it was really important that we start to raise awareness of the toxicity of the drug supply, because we don't know actually what we're taking anymore. And in NWT, we're not as far down the road as we are like what we see in BC or Alberta, but it is really important at this point is to sensitize the Indigenous communities, sensitize the communities. And part of the sensitization is like what we want to cover is we want to let people know what drugs are in the community, the risks of drug poisoning, the dangers of mixing drugs with other substances, because frequently alcohol is depressant and people are mixing their drugs with alcohol, and it just increases the risk for toxicity. And what's most important is the danger of using drugs alone, because when we look at the individuals who, their deaths were unwitnessed, and naloxone, their deaths were preventable. If there was someone there who knew how to use naloxone and administer it, they would be alive right now. So, and that's also part of when we're doing presentations is to reduce the stigmatization around using drugs, because the family members, they want their family members to be safe, but if we stigmatize people to the point where they're going to go off alone, use drugs unwitnessed, we put them at risk as well. We also, the one thing about the opioid overdose is that there's specific signs and symptoms that people should be able to recognize, which we're trying to train people. And we're using the naloxone spray, which is pretty easy to use. We want people to be comfortable with recognizing signs and symptoms, specifically about opioid overdose, because that type of toxicity is something that someone can do right away. You can call 911, but you can literally save the life right away if you have access to a naloxone kit and you're trained on how to use it. There is, for reassurance, typically people are using drugs with other people who may be using drugs, and there is a Good Samaritan Drug Overdose Act, so that if you were using drugs or you had a small amount of drugs, but you witnessed poison or overdose, you can call for help without fear of being incriminated. And the we have done multiple presentations across NWT to sensitize people about this, but going forward over next 2 to 3 years, there are things that we need to specifically work on, and one is we have to continue this toxic drug campaign, so that in a way that people are demanding posters, they're asking for social media, so that it's that everyone's aware, from youth to elders, about the drug toxicity that we're seeing not only in NWT but in Canada overall. And then what people are asking, they're asking for drugs 101, like someone who has stimulant toxicity, what does that look like? Someone who's overdosing or being on opioids, what does that look like? What if it's mixed? What happens? And so we are working with MWAR and NTHSA, as well as the Community Culture Innovation Group, to develop high-level Drug 101 information pieces that will be available on our website, but with the NWT context, because we're not going to just borrow something from Canada and put it on. We want to develop our own materials based on the questions we're getting. There is another community-based workshop toolkit that we're working on, and we're going to continue raising awareness through leadership discussions. Again, naloxone is core funded and is available through emergency room, health centers, and retail pharmacies. But during this particular period of the campaign, it is an expensive kit. When we first bought it, it was about $200 a kit. So we had basically access third-party funds to have a surge in supplies, so that we can try to provide naloxone kits and training to many people who need it. So that's specific to opioid toxicity. That's what we're trying to do, and that's it. End of my presentation. Thanks for your time. Chair, over to you.
Thank you, Dr. Candola. the chair notes that Mr. George Nersu, the MLA for Mackenzie Delta, and Robert Hawkins, the MLA for Yellowknife Center, have also joined our hearing today. So thank you very much for the presentation. We'll now hear from committee members with questions they have for our witnesses. And I assume we'll start with Ms. Morgan.
Oh, sure. Thank you, Mr. Chair. Thank you so much to each of you for coming and giving us such important context and information, but also just being a resource to answer questions. I think it's a really important topic, certainly for our committee members, but for just about everyone in our ridings. One thing I wanted to ask about, so you touched on the managed alcohol program, which started during the pandemic. My understanding is that from the GNBT's perspective, this has turned into a quote-unquote access to alcohol program rather than a proper managed alcohol program because of like lack of resourcing in terms of nurse or doctor supervision to actually help structure the program in a more managed way. I'm wondering if either the public health officer or HSS has either recommendations or plans to go back to a more like managed alcohol program with medical supervision, and also whether you see potential to expand to say a drop-in service, to offer something like this at the day shelter or the new wellness and recovery center. I know right now it's sort of like as part of a residential program in the Spruce Bough, but I know in many other places in Canada and larger centers it can be offered at drop-in centers and then expanded to more people who might need it. So that'll be my first question. Thank you, Mr. Chair.
Thank you, Ms. Morgan. Who would like to respond? Okay, I'll try this. Skowski, is that? All right, go ahead.
Thank you, Mr. Chair. That's a very good effort. Yeah, I think like you're right. The program that started during the pandemic that's currently running at the Spruce Bough, like it is more of an informal access to alcohol program, which is not necessarily something that is inferior per se. Like it's still providing a similar service and taken in conjunction with being delivered in the Spruce Bough supported housing setting. It is providing like a really important stabilizing support for people who need that service. Looking at, whether it needs to be a formalized map with strong medical oversight is something that we're looking at going forward. Like Ms. Gilmore mentioned in her presentation, this has been a program that has been around for a few years, but it has lacked ongoing sustainable resources to support it, which obviously impacts the delivery of the program. And so really what we're focusing on now is doing the evaluation and the monitoring of that program to really understand like how is it working and how is it benefiting people, and from there we can kind of take those lessons learned and those pieces of evidence to determine what it might how it might be best structured going forward. We do have standards that are in place to guide the delivery of the managed alcohol, just to make sure that we do have currently there's really only the one community-based site, but in the event that there were more, we want to make sure that there are those common elements and those common pieces of oversight and safety considerations that are being provided universally. But I think in terms of the future, what it looks like, we need to look at the evaluation results and continue to monitor it. And then the other piece that I was your other part of your question was around whether we would consider doing like a drop-in model of something like this. I might just do a bit of like an initial response and then maybe pass it to Ms. Gilmore to add to, because she's definitely our resident literature and research expert. But one of the things that we would maybe have some cautions about that type of approach is that from our experiences with the existing Spruce Bough program, and particularly during the pandemic, we have seen some of the challenges that can come from mixing a population of people that are accessing managed alcohol, trying to create some stability, some safety, maybe work on other areas of their life. They have health issues that they're trying to work on, and mixing that population with a population that is still out, maybe more in a street entrenched lifestyle, maybe without that stability, actively using, it can be difficult on the people that are trying to find the stability to be mixing those populations. And also, just what is really helpful with MAP is that you are controlling the alcohol that people are taking in, and you're able to provide that stability and that safety. But if it was a drop-in basis, people are probably more than likely still using alcohol from other sources and potentially non-beverage alcohol. And so there could be risks associated with providing like additional alcohol to them when we don't really have any oversight of all the alcohol that they might be intaking or where they might be getting it from. But if it's okay, I might just pass it to Ms. Gilmore to add if you have anything to add, Shauna.
Thank you. Ms. Gilmore, go ahead.
Yeah, I mean, I echo everything that you just said about the considerations around mixing populations of people. I think the only piece that I'll add is with managed alcohol programs in general, what we've seen in the literature is one of the most kind of critical components of success for a program like that is actually housing and stability of housing. So like that is a piece that is really important. So if we're looking at something like the day shelter versus something like for example a transitional housing type service that has a managed alcohol program attached to it, the success rates for people in that type of a service is certainly going to be much higher than in something like a day shelter setting where there is a lot more transiency in the population and a mix of people in terms of where they're at on their recovery trajectory.
Thank you. Ms. Morgan, follow up?
Thank you. Thank you, Mr. Chair. Okay, I appreciate that. I mean, I understand you must be aware of best practices, and you've obviously surveyed literature from across Canada and other parts. I mean, my intention here is not to sort of condemn what we have or haven't done yet, but just sort of look clear-eyed at, what we've attempted so far, the programs we've attempted so far, and where the potentials are to go from here. Not to say that what we've done so far is right or wrong, but can you give some assessment based on your knowledge of where our current sort of access to alcohol program stands in relation to best practices of managed alcohol programs from other parts of Canada? Like, do we implement most of the best practices that are seen, or do we still have pretty far ways to go in terms of matching up to best practices in managed alcohol programs from other parts of Canada?
Ms. Trzaskowski?
Thank you, Mr. Chair. Thanks for the question. I think, and again, I might just take an initial stab and then pass it to Shauna if she has anything to add. But, I think managed alcohol can look a lot of different ways. Like there's not a cookie cutter approach across the country. There's lots of different approaches, and I think all of them probably can be considered good and promising practice, but it kind of depends what outcomes you're looking for. And I think although we're still in sort of the early days and still in sort of a monitoring and evaluation type phase with the program, I think what we do know is that the managed alcohol piece is one example of a supported service that's available at the Spruce Bow supported housing program. And I think to Shauna's point, the fact that housing is there and the stability and the safety that having supported housing that you can be successful in, I think that is one of the key elements in terms of getting the most out of a managed alcohol approach. And the other thing I would just add is that I think when it comes to managed alcohol, or when it comes to addictions and the different options that we use to support people that are experiencing addictions, it really is a spectrum. And, managed alcohol is something that's available for people that maybe are not interested or can't stop using, but it's a way to support them to be as safe as possible, even though they are using, and to still provide them with other supports and services. It's not necessarily something that every person would be ready for, especially if they are still using other substances in other areas of their life outside of the program. So I think it's just the one thing I would caution before I pass it over to Shauna is that it is just sort of one example of what we can provide for people. And it's not something that is necessarily an answer or something that should be offered to every person who, has substance use disorder. But Shauna, do you have anything you want to add?
Ms. Gilmore?
Yeah, so I think the thing I would want to add is that we did develop a set of standards, and I will say that the standards that were developed are very much in line with what's happening across the country in other jurisdictions. There is quite a bit of variability, and managed alcohol programs, again, are relatively new in the context of substance use services. So there's a lot happening in the research field, collecting evidence on different approaches and what works and what doesn't. And I think a piece that is really critical, especially for us in the NWT, is to make sure that if we are adapting best practices from other jurisdictions and regions, that we are looking at those practices kind of through the lens of our own northern context and our community's context, because what might work really well in Vancouver's downtown east side may not be, necessarily the best approach in our communities here. So certainly like being informed by what's happening elsewhere, but making sure that we're kind of adding kind of that individualized approach with what fits for our residents and what they need the most.
Thank you. Ms. Yakalaya, you have the floor.
Thank you. Thank you for the presentation. It's very good, informative. Question I have is, given that we don't have treatment centers or detox centers in the Northwest Territories, and the harm reduction is something that is doable and and I like the fact that you mentioned that things don't work in the north like they do in Vancouver. So taking into consideration the communities, what the community needs, because the communities here in the north, they know what they need. But the funding, the training and awareness, all that stuff, if these things were to be implemented in the communities, that stuff will have to be, I guess somebody will have to incorporate those or apply for the funding and get that so it's working. My question is, what is the public health or CHRs doing to educate the public on these topics in communities? And the second part to that question is there training programs available for community health support staff and reps so they can look at delivering these programs in the communities? Because in the smaller communities we're facing, you could almost say it's a pandemic of, the addictions and stuff that's happening in the north. So that's my question. Thank you.
Sir, Dr. Candela?
Thank you, MLA Yakale. So last year, with some specific funding, we were able to gather video testimonials of people with lived experiences or families struggling with addictions, people who went on to recovery that were NWT specific. And with those video testimonials, we are working on a train the trainer workshop kit with a facilitator guide and a participant guide. And the aim of that is to provide training to community wellness workers and CHRs and anyone else who's working in the area of harm reduction or addiction to be able to deliver these workshops in their own communities. So we're in the process of working on those materials now, and we are going to do a trial run in February, but we're hoping to, we have funding for this, that once we develop and trial test these workshops, that we will have regional workshops where we will go to the regions, that includes DHO, and start doing training the trainer on these materials to raise awareness on drugs, but also to make inroads on recovery and harm reduction. So that is in development as we speak.
Ms. Gilmore?
Yeah, I'll just add as well that it's a slightly more broad, but we also at the Health Authority have added a number of facilitators across the territory in different regions for partnership with the Mental Health Commission of Canada to facilitate mental health first aid training. So that's the Northern Peoples course for mental health first aid, and a bunch of us were trained as facilitators earlier this year, and we've been providing workshops throughout the territory. It's like a 3-day, full-day training that we do with different groups. They can be, community groups or with the public, and we've seen a lot of success with those facilitated programs as well. So that is something else that we're offering right now that's actively happening.
Thank you. Ms. Yekalaya, you have a follow-up?
Yeah, that's great. That's awesome. I'm very happy to hear that because, like I said, we don't have treatment centers or detox centers anywhere that people can just go and get treatment for it. So this seems to be a way to go for us right now. So the trainings and stuff, they will happen in each region. Are you in communities together from one regional center, or how is that being worked out? Thank you.
Dr. Candola.
So first, we're developing the materials. We'll test them in February. We're working with the Community Justice Program. They have a conference. We'll be trial testing some of their staff and some of our own community wellness workers. And when it passes that test and it's ready to deliver, we have funding for the next 2 fiscal years, not including this, to go to the regions and deliver the workshops regionally. So we would go to Fort Simpson, Hay River, Fort Smith, Inuvik, Norman Wells. We'll deliver it regionally, and have funding to bring critical people into that workshop from that region. So someone from Fort Providence would attend that, Wrigley, KFN, Podecho, those outlying communities. We feel that if we bring the training right where the needs are, we'll get more participation. And because we're using NWT video testimonials throughout the full journey around addictions and recovery, it will resonate better than just important and Southern-based programs. So there is a 3-year timeline for this, and the workshops will start next fiscal year, so likely April of 2025.
Thank you, Dr. Candola. Ms. Whalen Armstrong, you have the floor.
Yeah, thank you. Thank you for the presentation. Just like what my colleague said, it's very informative. I know that in my region here, and people have been inquiring about the detox, and I think they would like to see something, because sometimes in order for some people to go out for treatment, and there's a steps, there's a process, but sometimes they would like to, I know Yellowknife is close by, but they need some kind of a center where they can go before they move on. So I'm just wondering if the department is working with Indigenous government or other group to possibly have a detox. Because I know that some of the treatment works for some people, and some the online on the land works for some as well. So I know. So I just want to know if the health department is working with Indigenous government to come up with some kind of a plan to help our people, because we know that in small communities in the regions, we do have a crisis, especially with the crack and other mental health issues. Thank you.
Yes, Ms. Sierkowski.
Thank you, Mr. Chair, and thanks to the member for the question. Yeah, we recognize that detox has been a gap in the territory, essentially. It has been available at Yellowknife and Inuvik hospitals, but not in really a dedicated program-specific way. So that is something that we are taking steps to remedy. The NTHSA is leading the establishment of like a territorial addictions medicine program, and one of the key and primary focus areas of that will be the establishment of detox beds and associated processes to access them at the Stanton Hospital. So there is a vision to also have community-based detox supports, but the priority is getting those detox beds in place at Stanton first. And the reason for that is really just because if you're going to offer community-based detox or withdrawal management services, you really do need to have the availability of a step-up medical detox in case that becomes necessary. So, you know, if somebody were to go into distress in the community, you would need a place that you could bring them at the hospital. So that's the rationale for prioritizing the beds at Stanton. So recognize that those are needed, that people have been looking forward to those, and I can't give like a specific date as to when those beds will be available, but what I can say is that there's significant work going on, and we do expect that those will be available in the near future. Thank you.
Can you give a more, like, what does near future mean? Are we expecting, like, within the life of this government, is within the next fiscal year?
Thank you, Mr. Chair. Yes, absolutely, within the life of the government, and I think it's probably, I would look to my colleague at the NTHSA that's the lead, but I think hopefully within this fiscal year. Yeah.
You've been volunteered, Ms. Gilmore.
Thank you so much, and thank you for the question. Yeah, the project that's underway right now is, it's a multi-year project, and it's something that we really want to make sure that we're doing it right. So it's involving multiple levels of the health system. So it's not just Stanton Hospital or acute care. It's also, you know, including primary care, community care, you know, some of our NGO partners to make sure that everybody's being connected kind of with that wraparound approach, right? As I said in the presentation, we know that like detox on its own isn't a treatment for substance use disorder and doesn't really show good impacts on long-term recovery. So it's what happens kind of before and after that are really the most critical pieces. So getting people into those beds when they need them, or, you know, facilitating, say, a community-based withdrawal in someone's community when they're stable enough to do that. That is really important, but if we don't have, you know, things lined up, those processes in place to make sure that people are continuing with a treatment plan afterwards, then we'd really be missing the mark. So we want to make sure that that's happening in the right way, so that people aren't kind of falling through the cracks after they, you know, they go to their detox bed and they kind of go through that experience.
Thank you. Ms. Sue Ellen Armstrong, you have a follow-up?
Yes, thank you. Okay, regarding harm reduction, and I know that there was quite a few of our people from our regions. I know a lot of families, they do care about their loved ones. So a lot of them have tried to take them back to the community, but because we don't have a program here in the regions for them, so a lot of them, they go back to Yellowknife because there's more services, there's more resources for them. And I know, sad to say, but there's quite a few, we lost quite a few as a result. So, and it says this opiate recovery program was expanded. I know it's not opiate, but there's other, you know, stuff here, that they were into. It's addiction, which is a disease, we know that. So was expanded from Yellowknife only to a territory-wide services in 2019. What kind of program is that? And is it just only for the opiate use disorder, or is it for other addiction, other programs?
Ms. Gilmore? Oh, Ms. Okay, Mr. Szyszkowski.
Thank you, Mr. Chair. Yeah, the opioid maintenance therapy program, the OMTP, which is being changed its name to opioid recovery program, that is specific to opioid use disorder. So that program is largely focused on that, but there are other options and services available for people who have other substance use disorders other than opioid use disorders. So I'll just quickly touch on some of them. Like I think people are aware we do have the community counseling program, which is available in all regions of the territory and is a key source of support for people, source of providing prevention and promotion programming options in the community, but also a key source of referral to more specialized options like facility-based addictions treatment, potentially also for people when they do need detox, when that program gets up and running. So that is available for people. We do have facility-based addictions treatment. Obviously, it's not, everybody knows it's not delivered here in the territory, but we do have those contracts with the southern facilities, and we are, members may be aware that there is work between the Department of Health and Social Services and Indigenous governments to look at ways that we can partner to see how we can enhance the availability of in-territory options for treatment and recovery. And then the only other thing that I'll just point out is that recognizing that those community-based approaches that are close to home and that are based in cultural and culturally safe are so critical to success, the department does also offer the Community Wellness and Addictions Recovery Fund, which is prioritized to Indigenous governments, but also available to other groups. And that really is it's about $3 million a year in total, and it does have a set allocation for Indigenous governments. Multi-year funding is available, and it's really there to support, you know, the development and the delivery of community-based, culturally safe mental wellness and addictions recovery options for people. So it could be land-based healing, it could be aftercare supports, it could be Indigenous counseling supports. And I do know that in the members region, the Cleachville government is making very good use of that funding and providing some really comprehensive and wraparound supports to people using that funding, other funding as well, but that funding is a part of it. So I'll just pause there.
Thank you. And committee has attended the Gwich'in Tribal Council Wellness Camp in Inuvik and the IRC camp as well, the Inuvialu Regional Corporation camp. And we're quite impressed with what they're offering. But of course, it does fall short of a full treatment program. But we do know the Indigenous governments have taken quite a keen interest and are making good progress. Ms. Whalen Armstrong, I sense you might have another question in there.
Yes. Well, it's more of a comment, but and Ms. Yakula touch on it too as well. The CHR and the public health, you know, working with the school. So I did heard about the trainers, and I heard that it was a good outcome, and it's very informative. Even here with the CHR and the public health nurse, or you know, that department working together. I know that there's a lot of people that are, you know, especially the elders and a lot of other people. They like listening to radio, and they when the CHR, because you know they're working closely with the health department, so when they go on the radio, it's very informative, especially when they're talking about, you know, like wide range of health issues, drugs, and it's I think we need to see more of that, because I know when I was talking to some people, they did say, how come they're not going on the radio as much? And I think those kind of public education is very important for a lot of our community members. That's how they get that's how they stay connected of what's going on, because not everybody has access to the internet. And so, and especially for the elders, you know, like, so it's a good tools to have. And I think I did hear, I'm not too sure if the department is trying to expand more programs to work with the school. Is that going to be starting this this upcoming school year in the 2025 to do more training? Because train the trainers, and I know that well, this is, you know, in our school, in a lot of the schools, we know that young kids as young as 12 years old are experimenting with drugs. We know that. So I just want to know if it's going to be coming anytime sooner to other small communities. I know that I know in the Klitschko region it's probably going to be ongoing, but I would just want to know if the services are going out to other region as well. Thank you.
Dr. Kendall.
Thank you, MLA Armstrong. Our office has a very strong relationship with the TCSA. We had hosted 2 public health competency workshops for Klitschko when we had the CHRs, the physician assistants, there was paramedics, and some of the nurses come. We provided training. We provided naloxone training, and as well as training on syphilis and HIV testing and immunizations, TB. So we had provided this general public health competency workshop specifically targeted to Klitschko because of their interest and demand, and they themselves had initiated their own naloxone training workshops. But we do when we did this, it was just a one specific skill workshop, but it did elicit interest in other what we're hearing after we do these basic workshops is people want a deeper knowledge on drugs. They want to know the types of drugs, different types of what to do, a deeper understanding of those, as well as an ability to reach out and help people who are at risk. We will, in that campaign, we will obviously target CHRs and community wellness workers, physician assistants in the communities, and that would include the Klitschko. Where we would want a stronger relationship is directly with ECE, but if we train the CHRs and CHRs have access to the schools, that's great. But going forward, one area that we would want to work more closely with is directly with the schools around youth prevention, because this is something, when I've been traveling around the territories talking about illicit drugs, and I've talked to elders, everyone is focused on the youth. People don't want drugs coming into the community, and they don't want the youth to start, and they want the youth to know what's out there and the impact on their health and the toxicity. So that is an area that we definitely would want stronger relationship with ECE to explore further. But in the interim, we can definitely continue to train our CHRs. And when we're doing the campaign, the communication campaign, it has to be more than just posters, social media ads. It would include radio as well. So I will make a note that when we talk about radio, it's not a prefabricated kind of clip that we will have work with CHRs. Maybe they can do a live discussion to the elders in their own Indigenous language as part of our campaign. That is actually an excellent idea, so thank you.
Thank you. Dr. Candola, I'm curious about the supply chain for street drugs and the toxicity, because it seems now, like, of course, there's always been a risk with street drugs, but when I was a kid, it seems like there was more of a sense of, like, you know, don't do it, but you're probably going to survive. Yeah, and now it seems like all we see is these horror stories. So is this likely to remain persistent? Like, is this going to be, if the supply chain corrects itself and we see, like, those South American connections open up and, like, go back to the way it was, are we going to see a decrease in toxicity, or is this the way it is now and the way it's going to be for the foreseeable future? Dr. Kendall.
So the reason why I've been so, like, the NWT, we're at this point, we're not at the same situation as BC, but we're seeing the toxic supply chain. We're seeing drugs becoming more organized, that we're seeing infiltration in small communities that we have never seen. And then we see people deliberately trying to create a demand by giving free samplers or really low cost of drugs. And some of them are spiked with or contaminated with opiates, so you can basically make sure you have an ongoing customer base. So we see an organization of the criminal activity in the South and how they're organizing themselves to maximize their profits. And it's very, very sad to say, but when the supply chain was disrupted, and so instead of pure cocaine and crack that they were adding these fillers or adding fentanyl, what I know is that there are two Mexican cartels that's responsible for pretty much the bulk of fentanyl distribution in the U.S. And it is so cheap to make synthetic opioids at this point. It is so cheap. They would reduce their profit margin if they went back to try to get the natural supply chains. It's not a good business model for them anymore. So their business model is to maximize profit with the cheapest materials, and the cheapest materials are their own illegal manufacturing laboratories. And Canada gets precursors to manufacture their own fentanyl. So this is not going to change. This is about raising awareness now in our youth. The margin of safety is different than if you were taking 1 or 2 beers or smoking a joint. The margin of safety when you go the illicit drug route could be that we have scenarios where people split a pill and one person dies and one doesn't. So one of the things is that when you look at how little the amount of fentanyl you need to actually die or become life-threatening is about 10 to 15 grains of salt or 2 milligrams of fentanyl. That's all you need. That could be easily in a pill form. I have a really strong relationship with RCMP. They're a good source of intel. And they're also, we recently did a health advisory on the parafluorofentanyl that came in the powdered form in a drug seizure. But recently, just as yesterday, RCMP was saying, watch out, because they're taking this and making it into a pill form that looks like an oxycodone pill, one little pill, but it's really fentanyl. And so it's about being aware, parents be aware. If you're going somewhere, if someone supplies a pill and you don't know where it's coming from, it's not coming from a pharmacy, don't take it, because you don't know what could be in it. For the cannabis and the alcohol, stick to our regulated distributors, like our alcohol supply for the government here. That's regulated, but it's about being aware. We also are providing bundled messaging with people who are taking illicit drugs, is to go low, go slow, let someone know, so that if they inadvertently are displaying signs of overdose or impact on their vital functions, like they're breathing, if someone's watching them, they can call for help and they can at least provide naloxone. So that's part of our bundled messaging. But I feel it's really important that we raise awareness. And youth prevention can be providing alternate activities other than people feeling they need drugs and alcohol to have a good time. And that's part of the prevention package as well. So it's not going to go away. It's not going away. It's just getting more interesting, unfortunately.
Well, thank you for that. That's an important perspective, because I think there's always, you can definitely sense, if you've lived a while, you can see that sense of things have changed, and there's been an escalation of danger, and it's not just experimentation, right? Like, you're taking your life into your own hands as a young person if you're taking a pill, right? So it's important to be mindful of that. Do you have a perspective on the decriminalization experiments that have been undertaken in some urban centers? Because there's been mixed results, like Vancouver's now reversing what they've done, because it seems like there are public health issues created with kind of allowing people to openly do drugs in public spaces. Have your colleagues been able to take a look at that now and determine if those pilots have been successful, or what we should be thinking of when it comes to decriminalizing drugs, if it's an effective tool of public policy? Dr. Candola.
So I always I look at our NWT context, and when you were looking at decriminalization, decriminalization is the possession of 2.5 grams of things that were originally labeled as illicit drugs. But if I tell you that 2 milligrams is enough to cause a lethal overdose or poisoning, if you just have decriminalization without strong supports, or in a context here where in NWT, people overall are not seeking opioids. It's not, they're mainly using crack cocaine. So if you decriminalize crack cocaine and it's contaminated with lethal amounts of fentanyl, carfentanil, what you'll see is an increase in deaths. So for myself, I don't think NWT is at the stage where we can look at decriminalization. What we need to do is raise awareness around toxicity, give people the skills to recognize signs and symptoms of overdose, but also be able to provide access to treatment and recovery programs. The difficulty with people who are smoking crack is that they may not access an opioid recovery program because they don't know that they're addicted to opioids in the crack. So it gets really complicated. But decriminalization is not going to prevent drug deaths here. It'll actually increase drug deaths here in NWT. That's all I can say.
Thank you. No, that's clear and concise, so thank you for that. We're going to go to Mr. Narasu, and that will be our last round of questioning. Mr. Narasu?
Yes, good afternoon. Thank you, Mr. Chair. Can you hear me fine?
Yes, we can. Proceed.
Are you able to hear? Okay. Okay, I'd just like to thank you for your presentation. It's very informative. In my community of Fort McPherson, we had a very active interagency group that was taking on the fight against the drug trade within our community, because we had people from down south out of the community coming, even from Inuvik, coming into our community and setting up, taking over homes here in our community. And we were very concerned. We had resource people from all over the community here taking part in trying to find a solution, trying to get our resource people together. And today, I don't think the interagency group has met in a few months. The main reason for this is because every time we have the meeting, we ask the RCMP, like, what they've always stated, that they need the community's help in fighting crime. So we've been very active in trying to assist the RCMP in fighting this very serious concern that's happening today within our community. But this group hasn't met in a number of months, mainly because they don't have the support of the RCMP in our community. The RCMP, we give them, there's people in the community give the RCMP tips, and they apprehend a drug dealer. They hold them for 24 to 48 hours, and they release them, saying that they promise to appear in court. And obvious, everybody knows it, that they will just go back down south and they'll never see them again. And the drug dealers down south will send somebody else. So that's a cycle we've been going in. So right now, what the drug dealers are doing is using our own people, our own local people. Our own local people are killing our own people. That's where it's coming down to, and we're really having a tough time to address this concern. It's holding these regional meetings and inviting surrounding communities, whether it be the indigenous governments. I don't know if it'll be wise to invite the indigenous governments from my region anyway, I'm saying, because I don't know how much of an influence they're having on our community, but inviting the resource people, the CHRs, the nurses, the RCMP, because this drug trade is taking a big toll on their personal lives. They don't seem to interact within our community because most of their time is spent on crime that's associated with alcohol and or drugs. And hopefully if there's a regional meeting in Inuvik within the near future, that you can put out an invitation to these resource people so we can try to find some sort of solution. I just got a phone call this morning from a concerned citizen, and one of our local people who's dealing drugs that the RCMP knows personally, knows his name, stated that he made between $7,000 and $10,000 within that 24-hour period. And I don't know where all this money is coming from, with 15% of the community on income support. So, how can you address this concern of trying to help us fight this concern? And can you hold a regional meeting in Inuvik in the near future and invite the outlying communities to maybe, collectively come up with an approach? Because all our communities are suffering in the same manner. Thank you.
Thank you, Mr. Nersu. And of course, Mr. Nersu is touching on an interagency response, so the committee doesn't expect you to speak to areas outside of your departmental or your respective mandates, but to your role in that interagency work. Who would like to respond? Mr. Zasky? Go ahead.
Thank you, Mr. Chair. I think what the member's pointing out is the critical importance of a comprehensive approach where all the different parties are working together. I absolutely agree with that. I think this is not a health and social services issue. This is not an RCMP issue. Like, this is a across the board, whole of government, including communities issue, where it is going to take everybody working together to come up with, creative solutions. This is a very challenging and difficult problem, and so there's probably no easy solutions. But what I can say is that Health and Social Services absolutely does support a whole of government approach and a community-based approach as well. And I think that's what we've talked about here a lot today, is trying to work individually with communities, trying to understand what the needs are at the community level. Every community is different in terms of the priorities that they have, the resources that they have that can come to the table to support. So I think, certainly we do see that. One thing I do want to point out is that the department does co-chair alongside the Department of Justice, the Territorial Committee on Problematic Substance Use, which does have representation from a variety of GNWT departments, as well as like the Association of Communities, the RCMPs at the table. And it really is a really good forum where we can share ideas, collaborate, try to tackle this problem and figure out how we can work together on it. So I hear the member on that, and I would agree, and I would say that Health and Social Services is willing to be there. I can't comment on who operates the interagency in his community or in the region, but I think, our Health and Social Services staff that are working in the communities, we think that they should be an important part of that, and so I think if there's a problem with that, we would like to know that if people are not coming to the table. In terms of arranging a regional meeting, I think, what I would say is what might be most effective is to work community specific, and we have some different ways that we hear from communities and hear from regions in terms of what their priorities are and what their needs are. We have like the Indigenous Advisory Body that has representation. We also do one-to-one work with communities around community wellness plans, and they're planning for those. And so where there is a priority of addictions or illicit drug trade in the community is a priority for a community through their community wellness plan, that might be a really good forum for us to look at community-specific options and how we can support the work that communities want to do in that area. I would just pause and see if any of my colleagues have anything they want to add to anything I've said. Cami?
Nola?
So I have a good working relationship with RCMP. Where I get my intel in terms of when I issue public health advisories is like through free sources is healthcare practitioners when they're doing just routine toxicology on one of the, and we come up with high-risk drugs, unfortunately from the coroner's office, and then RCMP around drug seizures. So, and also the intel of how the drug trade is moving and becoming more organized in the north. So some of the points that were touched upon are correct. Typically they will move it. They will target a community. Now it's even small communities. Is pretty much no community is immune except for some of the remote Bodell communities like Willahuktuk and Sax. But pretty much every community has been targeted. They go in. They'll take over low-income housing. Distribute their drugs. They like picking youth to distribute their drugs because they have less of a risk for get off light in terms of if they got arrested. They also target young women, young moms. When the individuals talk about income support, in some places, the moment the income support gets deposited, some of the drug dealers come in the early morning hours and they're trading. That's why sometimes you won't see them. They'll be there between 12 and 2 in the morning, and they will be doing their sales then. So they have, this is very systematic and organized approach, and they have an MO. That what is dangerous sometimes when some communities want to take things in their own hand is that some of these individuals that they send 1 or 2 young males into these communities, they are coming with guns. So just FYI, this is vigilantism. It's going to be high risk. They are coming armed. So even though they themselves may not be physically strong, when they have a gun, they are a dangerous threat. So that's what RCMP is seeing more guns. What RCMP has said is call Crime Stoppers, because some of these individuals, their families are being threatened or people are being threatened. There's this sense of fear of the communities to come forward. But if they come forward and they don't, can't provide like more substantial evidence, it gets very difficult to prosecute. So this is what I'm hearing from the RCMP on this issue.
Thank you. Mr. Nersu, follow-up?
Yes, the other one that I have is in reference to alcohol and bootlickers within our. I'm always going to use my community because where I see everything. We have a number of people in the bootlicking right here. There's even people coming from other communities to bootlick. And it's evident that these users of alcohol need these bootlickers. It's the only source of where to get their alcohol from, because there's no outlet. The closest one is about 180 kilometers away, and most of them don't have any vehicles, and so they use these bootlickers. And if these bootlickers are taken out of the equation here, they resort to other substances that's store-bought, and and hairspray and all that. They turn to that. So would you say it's a good idea to have some sort of a liquor outlet within the smaller communities to, like if they had one, and I talked to a number of people, and they said if they had one in the community of Fort McPherson, it may cut down on the bootlicking industry, and this will enable the RCMP to, like saying that you can't bring over a certain amount of alcohol within the community, or you can't bring any alcohol into the community, because we already have a source within the community that will probably benefit everybody rather than just benefit one group of people. So my question is, would you think it would be beneficial to have some sort of an alcohol outlet within within the smaller communities? Thank you.
Loaded question. Mr. Trzaskowski.
Thank you, Mr. Chair. I'm not, like, I'll be honest and say that, like, I think that falls a little bit outside the realm of health and social services. It might be a better question for finance. Like, we don't have any jurisdiction over those types of things. I mean, certainly we recognize the harms that come with drinking non-beverage alcohol, absolutely. But being that we're not involved in, the policing and...
I'm not asking if you're make that recommendation. I'm just asking if it's beneficial. You think it's beneficial because it is harming the individual if they don't have access to it. If they don't have access to drugs, then they're going to break into places and they're going to start more crimes. So my question is, would it be beneficial for somebody's health rather than resorting to a substance other than alcohol?
Thank you, Mr. Nace. I'll just remind members to just ask your questions or comments through the chair. So even if you want to interject, just get my attention and we'll give you the floor. So specifically, I guess, if we can make this...
Mr. Chair,
Sorry.
Bye. I'm leaving the meeting. Bye.
Okay, well, we will ask Mr. Nersu's question, and maybe to make this easier, just from a harm reduction perspective, is there value in having a supply of alcohol in a rural and remote community versus versus no supply where bootleggers are, and there's criminality associated with that illegal supply? Is there a harm reduction solution to this, or medical evidence-based solution to this, to the member's point? Okay, Ms. Gilmore?
Obviously, this is a really complex issue, so I don't think there's a cut and dry response to this. I think from a harm reduction standpoint, one of the most important pieces of harm reduction initiatives is that they are tailored to the specific context of wherever it is that they're happening in, right? So to say, as a territorial health authority or the Department of Health that, yes, this is something that we would recommend across the board for every community, I'm not sure that would be the approach. I think it would be something that would have to be looked at community by community, what's happening in that specific community, what is the problem that we're trying to address there, and would something like this be of value there? But I don't think it's something that that would make sense to say, like, there's a blanket response that, yeah, this would be appropriate, or no, it wouldn't be. I think the context is too critical, per each community in that situation.
Thank Mr. Skatsky.
Thank you, Mr. Chair. I think Shauna's right. I don't think it's something that we would give a blanket opinion on. But also, I think while there could be some harm reduction benefits, I think it's also possible that there could be some increased harm associated with it, right? And I think that's what Shauna's trying to get at, is that this would be, it's a community decision. It's not a health and social services decision. It would need to be based on the specific context and the goals and objectives of that particular community. But I think there's the risk for it to go either way, depending on the situation.
Thank you. No, that's fine. The answer doesn't have to be, a solid answer. I think it's important. The member's got a point. It's something that he's raised frequently, and we need to have those discussions around, because we know prohibition doesn't work. How we can make it work, I guess, is the idea, if that's what communities want to choose, and to minimize the risks associated with it, because there are benefits to decreasing consumption, but you tend to see an increase in criminality. So, this is the balancing act we have to play. So, thank you for your response there. Mr. Hawkins, you wanted to make a comment, which I will certainly allow, as long as... Mr. Hawkins?
Oh, there you are. Sorry, the whole screen dropped. What's the internet? I'm not sure what it is. Just making sure. Thumbs up if you can hear me loud and clear.
We can't hear you loud and clear. We can hear you garbled and unclear. So, yeah, the opposite.
Okay.
Any way you can improve your connection?
I'll do my best. I'll do my best very quickly.
Not any better.
Okay. I'm not moving in the sense of I'm trying to hold still as possible. I'll just say this quickly. I just want to say that I appreciate Dr. Kendall's perspective. I'm not going to attempt to paraphrase her, but what I'll say is that I am concerned about deregulating drugs due to the complexities of what they would be, and the issue is real-time concerns. As she pointed out, that if they're laced, it's difficult. Again, I'm not here to paraphrase her, but I think she well stated it. I also hear from the RCMP their concerns about open sites without supports, and so I would just exercise concern, Mr. Chair, because the connection's so bad. Maybe I'll just leave it at that. And I just want to thank the presenters for their presentation and say that I'm always willing to hear more on this subject because it's very important to downtown. We seem to truly suffer from this, and I would not give any impression that the communities have it easy. I know they have it tough as well. So by all means, thank you very much for their perspective, and I look forward to some evolving results on this issue. Thank you.
Thank you, Mr. Hawkins, and thank you very much to all our witnesses for your time today. This concludes the public briefing on harm reduction programs, and I'd like to thank members of the public who tuned in to watch our proceedings today. The public portion of this meeting is now concluded. Thank you.